So welcome again, everyone, to today's webinar, Guided Oral Surgery and Robotics. My name is Anna. I am an application specialist for Invivo software and platforms here at Osteoid. A little bit about us here at Osteoid. We are a pioneer 3D imaging software company specializing in the Invivo software, dental services, and cloud platforms. Originally created in 2004 under the name Anatomage, now Osteoid, our Invivo products and services have continued to be the standard in 3D digital dentistry community. Today, I am joined by renowned surgical specialist and clinical advocate, Dr. Nima Massoomi. If you are unfamiliar, Dr. Nima Massoomi is a board-certified oral and maxillofacial surgeon who has been in the San Francisco Bay Area for the last 15 years. As a native New Yorker, he obtained all of his education and training on the East Coast, where he attended the University of Pennsylvania and obtained his dental DMD and master's in education. He then attended medical school at Vanderbilt University, where he also completed his oral surgery training. This was then followed by a cosmetic surgery fellowship in 2008 at Ohio State, alongside Dr. T. William Evans, where he fine-tuned his skills in the management of soft tissue of the face. Most recently, Dr. Massoomi was part of the team that brought to market the first FDA-approved surgical robot called Yomi in January 2017. The Yomi robot is currently focused on the guided placement of immediate implants and will have the capabilities of performing a wide variety of oral surgical procedures in the future. Since 2008, Dr. Massoomi has been involved in organized dentistry at a local and state level. He is currently the 2024 president of the Santa Clara Dental Society and is on the board of directors of the California Association of Oral and Maxillofacial Surgeons. He is also an examiner for the State of California Dental Board. Dr. Massoomi practices in Cupertino, Los Gatos, and San Francisco, and has been a clinical instructor at the Department of Oral Surgery at the University of the Pacific since 2008. He has lectured nationally and internationally on technology use in oral surgical procedures and led numerous mission trips with dental students for the past 10 years. He will be presenting his knowledge and experience with a passion for surgery and the use of the latest technology to improve patient outcomes with us today, which brings us to our agenda, where we will dive into implant planning and the use of surgical guides, talk a little bit about 3D printing, our Invivo guide design files, fabricating temporaries and hybrids, and really dive into robotics in oral and maxillofacial surgery. Now, before we do dive in, there are a few housekeeping notes to mention for today. We will have everyone muted during today's session. Feel free to jot down any questions that you have in the Q&A box. I will save time here at the end to answer any of these questions that you do have, and any that we miss, feel free to send them to info@osteoidinc.com. But now, without any further delay, let me go ahead and minimize my screen and pass it off to Dr. Massoomi.
Perfect. Thank you so much, Anna. Let me share my screen with you all. All right, beautiful. Hopefully everybody can see the slides.
Absolutely.
All right. Well, let's get started, and I will try to zip through this stuff. I know it's a lot, and I wish we had more than 45 minutes or so to get through this. I want to leave a little bit of time at the end for questions, because I know there's always questions from the attendees, and Anna's going to be monitoring the chat in the question section, and then will stop me when appropriate. So the biggest thing that we always look at when it comes to these types of talks is that I like to always kind of go through like my own revolution and what my practice and how it's evolved since when I first started. So initially, when I moved out to the Bay Area, we started to get into surgical guides in 2011, and then when Yomi came online, I brought that into my practice in 2018. And then as of last year, now we're starting to do 3D printing in-house. So I'm going to kind of go through that progression. And so everybody can kind of understand a little bit, how I have evolved, how I practice oral surgery. When it comes to implant planning and surgical guides, obviously, you need to have all the tools and the gadgets and the toys. So, in all my locations, we have a CBCT machine. And again, I don't I'm not endorsing any product. I don't get any kickbacks from anybody. This is just my true experience, honestly, with the stuff that I use. But we use the Robotics machine. I think we have 5 of them over the past 15 years. It's a Korean CBCT machine that's got the capability of doing both 2D, 3D imaging. Intraoral scanners, we've used iTero in the past, but I've transitioned to 3Shape from Denmark. And it's just the speed is just remarkable. And then robotics, obviously, the only robot on the market at this point that's fully guided is going to be the Yomi, which is based on Miami. And if you want to get into that, obviously, you need the machine. You need to have a CBCT machine and also the intraoral scanner. And then with regards to 3D printing, I currently use the Sprint Ray, their latest version. In addition to that, also, again, you need to have your CBCT and your intraoral scanner. Um, so the question is always to guide or not to guide. And many practitioners out there that have maybe been practicing for 20, 30 years are like, why do I need a surgical guide? I get good clinical practices. And I'm just going to quickly just show you some of the cases as to, and these are cases that I get on a routine basis, as to why we need to be using surgical guides. So when we look at this X-ray here on the left, you would think, this is a fairly decent placement, but really the path of draw is not there for the restoration. So it really behooves us to be thinking from top down or from restoration to where the implant should be placed. So I always, think about that when I'm working in the Invivo software. I put the restoration where it should be and then really put the implants and move it in a direction where I get a path of draw. So if we look at this case, this implant is fairly decent, but it's still the path of draw wasn't there. And in addition to that, what we're seeing is that on the other slide on the right side is there's some cement, right? Because this was a cemented restoration instead of screw retained restoration. So I get many, many cases where we get patients that come in where the implant was okay at the time of placement, and then 5, 10 years later, they come in with extensive bone loss around the implant, and it was because it was not a screw retained restoration. So I'm a big proponent of screw retained restoration. So when you guys are treatment planning your implants, make sure that you place them in a screw retained position. I try to do that 99.9% of the time when I use the Invivo software. Another case here, to guide or not guide, this poor lady came in and then a dentist had put these implants in free-handed, but look at the positioning of these things and the difference in the platforms of the implants. So how are you going to be restoring something like this? So we had to take all of these implants out, put the patients through bilateral sinus lift, and then come back and do guided surgery all on 6. Another case here, a patient came in, had seen a periodontist, and multiple times they tried to restore this implant, which sits a little bit lower, and they could not. And then eventually they were able to get the restoration in, but then if you look really carefully, you see that the screw is broken inside the implant. So now the implant needs to be removed. Another case here, again, 3 implants in the lower right, where obviously no surgical guide was placed. They were not put in parallel to one another, and look at the restoration, which makes it impossible for the patient to keep something like that clean, which leads to periimplantitis. And another key point I want to make is that I'm not a big fan of splinting implants together, because from a hygiene standpoint, it really creates a lot of problems when it comes to cleaning and also eventual periimplantitis and then implant removal. I am removing implants on a daily basis when the restorations are splinted. Another implant, I just had a general dentist that sent this to me this week, actually. And it was placed by, another oral surgeon, free-handed. And then she's like, how am I supposed to restore these 2 implants? Can you take these implants out? And the unfortunate thing is that this implant company does not make the tools to remove their implants. So I unfortunately told dentists, like, send the patient back to the other oral surgeon, see what he can figure out, because, this is not something that I can fix, because I can't even take these implants out. Right, so it really creates for a really bad situation, both for the dentist and the oral surgeon involved. Again, another one I got this week. A patient was self-referred to me, where a dentist free-handed, obviously, implant number 30, and then she's obviously pretty smart. She's had other implants, and she looks at the X-ray and then asks the dentist, "Hey, is this normal?" And then so he kind of brushed it off, and then obviously she looked me up online, comes in, is like, "Hey, can you take this implant out for me?" The challenge is I don't even know what type of implant this is. So, I'm just showing you that just some cases that I've seen recently, why it's so critical for us to be thinking about surgical guides. Another one here, patient comes in severe bone loss on the left. Another one, if you see the implant is more buccal, like how are we supposed to put a restoration on an implant when it's in that position? These are all non-guided cases. So dental implants, what is the big deal? Why is everybody trying to get into dental implants, right? Well, if you look at basically the numbers out there, it's estimated that 20% of the world population has no teeth. So that adds up to about 1.4 billion people. And then at an average cost of $3,000 an implant, if you just add that up, you're talking about trillions of dollars in revenue from implants. And that's why there's over 1,000 different implant companies, dental implant companies in the world. And so that's why everybody is getting into this. But since it was, invented in the 80s, late 80s, 90s, there's been a paradigm shift when it comes to implant dentistry because, in the past we would do what we call two-stage. Now we're doing one stage where patients come in, teeth comes out, implant goes in immediately, or what we call immediate implants, right? And then before also we were doing what we, delayed loading. Now we're doing immediate loading. And freehanding is really moving towards guided surgery. So there's many of this stuff that we're seeing over the past 10, 15 years. I think a lot of it has to do with, social media and then this concept like, now. Most patients are not willing to go toothless for 6, months or more. They would prefer to have something that's immediate. And thankfully with technology, we can really deliver to patients that type of need. Okay. So this patient was referred to me, sometime it was at 12, 13 or something. And it was, a student at Berkeley, fell in the tub. And then later on, they actually found out she's hypothyroid. And then she was sent to me by her general dentist. And they had tried to do all they can to try to restore that tooth with a crown buildup. But as you can see, that this thing is so bulky and so unaesthetic that she just was not happy with this, right? So, in a case like this, when a patient comes to me, am I going to freehand something like this? Absolutely not. These are the cases that I use surgical guides for. Okay. Another patient that was referred to me, self-referred to me, last year, she's a physician and, Stanford, Palo Alto area and high smile line. She's been through orthodontics twice. She had, braces when she was younger, had Invisalign recently, and unfortunately, the dentist free-handed implant number 7. So, and if we take a look at the restorative space of number 7, obviously does not equal or match the other side. And then if we take a look at, the restoration, this is not something that's really pleasing to her. So she came to me, she's like, what can you do? I was like, nothing. This implant's got to come out. There's nothing I can do for a case like this. The implant is countersunk, it's too far facial, and restoratively, it's impossible to make something like this aesthetic, right? So then how do I take this implant out? Sorry, how do I take this implant out? So if we take a look at our X-ray, you can kind of see that they squeeze this implant in, and it's literally on the CT scan under a millimeter between the roots of the adjacent teeth. And I was like, there is no way I can remove this implant. So guess what happens now? She's going back to orthodontics for a third time. And so if you take a look, I sent her to an orthodontist that I work with closely in San Francisco who does what they call incognito or lingual brackets because she was like, there's no way at this age I'm going to put wires and brackets on my teeth. Have to see patients, is there any other options? I was like, well, you got to go to this guy. So, she goes in and then she's been in treatment now for almost a year. And so he's trying to actually open some space so, because when I go into these cases, I gotta take the worst case scenario because if I cannot take this implant out with the implant removal tool that usually the companies themselves make, I have to try find this whole implant out, right? So this is her case right now with the lingual brackets. You can see that he's got a spring between tooth number 6 and 8 is trying to push these teeth apart just to give me room to be able to put that trapline barrier just in case if it's needed, right? So some of the, I guess the basic principles I want to kind of bring up is that if you guys do not know how to remove implants, please, please, please do not freehand implants because you may be able to get it in. It may look okay for a few years, and then when the SHIT hits the fan, and when the implant needs to be removed, it really creates a problem. So I never do anything freehand in the anterior zone. So I'm always either using surgical guides or using Yomi at this point. And I, at this point, honestly, rarely ever freehand anything. I may freehand something, but it's going to have to be in the posterior, where it's not visible and it's got, amazing bone and have adequate, depth and all that stuff. So just, this is just my suggestion based on how much, the cases that I see that the implants need to be removed, is that please do not freehand implants, especially if you don't know how to take them out. Okay. So I'm going to just quickly go into how do we actually take implants out, because I think this is really critical for you guys to see. So implant removal can really be very atraumatic if it's the right implant system and if you have the right tools, right? And we want to be removing the implants atraumatically. What I mean by that is we don't want to go guns blazing and destroy all the jawbone in the process of removing the implant. So when we use a trephine burr, just imagine the heat that it generates and then the damage that could do the adjacent roots of teeth and others, right? So we're always trying to shoot for the least traumatic way to remove implants. And so, like, if you look at this case here, this case got sent to me. The patient was having just chronic, periimplantitis, and then this is just on opening. I didn't remove any bone. As soon as I played things open, this is literally what I'm looking at, right? So thankfully, I was able to, take this implant out using the what we call the universal implant removal, and you can kind of see the threads that are still in the bone. So that tells us that I didn't have to destroy the bone to take this implant out. So in this case, we take it out, we bone graft, and we come back and put another implant in using a surgical guide. This is another case where a patient came in with implants in the positions of 6 and 11, again, not placed with surgical guide. They were too far facial, and she actually had broken restoration to implant number 6. So there's no way I can even put any type of tool to take this out. So this is a case where I have to trephine things out. And for patients that don't know how we trephine these things out, this is literally what this looks like. So if you take a look at the amount of bone that needs to be removed to take these things out, in these trephine burrs, they're honestly one-time use only. They should not be reused. They have to be very sharp because once they get dull, they generate so much heat and then they destroy even more bone after you've taken the implants out. So I go into that case for the physician with the mindset that, hey, I may have to use a trephine burr. So that's why I was like, hey, lady, I'm sorry, I can't touch you until you go get orthodontics to move the teeth apart. And her jaw literally dropped to the floor, right? So, and sometimes what happens, even under our best intentions, when we try to remove implants atraumatically, we're not sure if we remove the whole thing. So I always x-ray the implant itself after it's been removed to make sure that the entire implant actually is there, that we haven't broken any threads or anything like that. So make sure that you guys take PAs of the implants that are taken out. But I have to stock all of these tools. And again, no, I don't have any particular preference to, one implant company or others because they treat me, with specialty or loyalty and other things. This is the implant system I use. I've used Nobel Biocare for almost 20 years. My mom has Nobel Biocare implants. They have all the retrieval tools. They've got all the guided kits. They've got internal irrigation. So this is my go-to implant system. And it's been like that ever since I got out of my residency. But for each of the implants that I house, I also have the retrieval tools. Okay. And, in each one of these things are specific to the implant platform and size. So if you look at the implant retrieval instrument, it tells you on the top that it's conical connection, regular platform, tri-channel, blah, 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 right? So sometimes people assume there's going to be one implant retrieval tool for every implant system. That's not true, okay? And so when it's taken out, that screw is basically reverse threaded inside of the implant. And these things cost about $150 a pop, but they're one-time use only. You can't reuse these tools. So literally what happens is once I take this out, I send it off to Nobel Biocare for further examination and testing and other things to determine, hey, is this a surface issue or something else? Okay. But it can take up to 200 Newton meters of force to be able to reverse these implants out. Now, unfortunately, not every implant company makes retrieval tools. And I've even had to call the reps up, and one of them had the audacity to tell me, our implants do not fail. And I was like, you've got to be kidding me. I can't believe you just said that to me. It's true that maybe your implants do not fail, but what if they're placed in the wrong position, right? So when we have implants that come to my office that we do not have like the tool to remove it, or we don't even know what it is, then I have to use what we call the universal implant removal system. And this is what they look like. And I've used this system. I got introduced to these guys almost 15 years ago at the beginning of my career. And it's a Spanish company. And they're one of the first to create these, what they call universal implant removal kits. And you can see that they have, about 4 to 5 different sizes of tips that go inside the implant to remove. And this is their older system. This is their newer system, which has got 11 different tips. And I would honestly say this is the best money I've ever spent on anything. So if you're in a practice that puts a lot of implants in, I would highly, highly recommend, not, doesn't have to be this system, but get at least some type of universal implant removal kit so you'd have it handy. And this will make your life so much easier because you have no idea the number of times I've used this kit where the implant just pops right out and I can immediately go back in and put a new implant in because I haven't shufflined that burr, I haven't destroyed that bone, right? And they say that they have a 98.4 success rate, and I honestly truly see that as well. It is really rare that I get an implant that I cannot remove with this kit. And at this point, they're compatible with 40 different implant companies, and they have a whole compatibility list that will go through and tell you, okay, this is the implant tip that you need to use to remove this implant system. Okay. The kit itself is $1,500. Each tip is $75. And if you guys are interested, I'm sure you guys can look these people up online, but it's BTI North America. So yeah, I highly, highly recommend that if you guys are doing a lot of implants, to please have this kit available. If that kit doesn't work, as I mentioned earlier, last resort, Trefline burrs. And again, BTI makes them. Many other companies make them. You just need to make sure that, again, you have a whole range of different diameters because you got to be able to get around the implants. But at the same time, you want to be fairly close that you're not removing too much bone. So you have to have a whole array of different diameter implants. So let's go back to this, Berkeley student that, came to me. How did I do this case, back in, 2012 and 2013, right? So, this is, the what used to be called anatomage, but now it's osteoid thermoplastic guides that were created. And you can see the middle cylinders. And then in these anterior cases, I would have them actually make me an analog model, which is basically a 3D printed model, which has the implant analog hole already actually drilled into into the actual model itself. And then I would take that and then send it to my lab. And again, I exclusively use California Dental Arts in Cupertino because they are literally behind my building. I could throw a stone at them, but they're amazing. And so they would actually make the temp for me before I go into surgery, right? So I would go into a lot of these interior cases with prefabricated temporary crowns, okay? So, and this was what they look like. So that's basically what we did for her. And then, so this is some of the clinical photos. So the tooth comes out. And then again, we use, and I'm going to show you some videos, periotomes to remove the tooth atraumatically, and then to try to, preserve as much of the socket as possible. But, you can see that again, I'm putting these in screw retain restorations so that, and when it comes to the final restoration, it makes it a slam dunk for the general dentist. Um, at this point, as of last count, I've done over 300 of these immediate implant cases with prefabricated crowns, and our success rate has been about 98.2%. But it really comes down to case selection, and I cannot stress this enough. I do not do this on everybody. And when patients come to me with anterior cases in the maxilla, the first thing that I look at is actually their lower jaw. Because if they have a deep bite, proclined teeth, the first thing I do, you got to go see an orthodontist. And I do this on a daily basis with no joke. So this is a case here. What I did not load, okay, the tooth, because if we look at the picture in the lower right, you can see that this patient has a very deep bite with proclined anterior teeth, right? This is not a case that you can actually go ahead and immediately load with a temporary crown. Otherwise, the implant's going to fail. And if you take a look, what I've started doing more recently is instead of just using the round healing abutment, I'm using innata temps. These are oval shaped temporary abutments that go on the implant that shape the mucosa to make it more oval shape. So again, when it comes down to the restoration portion for the general dentist, we don't end up with an apple on a stick situation, okay? So we're trying to shape all of that before we get to the final crown. So I'm just going to quickly go through and show you a video of, how do we use the thermoplastic surgical guide. So this is a kid that, was unfortunately born with 8 congenitally missing teeth. He was in orthodontics for 6 years, okay? And so finally got to the point where we were ready to place his implants. And again, hand wrist x-ray and other things to confirm that the patient has stopped growing. And then this is what he looked like prior to his surgery. So this is a video of us doing this case, and again, no music because I want to be able to kind of talk you guys through this part. So this is right before surgery, after he was grafted, the thermoplastic guide. And again, the reason I like to use Nobel is because if you take a look, we have these sleeves, right? So when you guys go to order the osteoid guides, they always are asking you, right? Hey, what type of guide are you using? You need to make sure you guys have the guided kit. It doesn't matter which implant system you're using. If they don't have a guided kit, then you really are not truly guiding, okay? So we need to make sure that if we're using a surgical guide, that we have a kit that's a surgical guide kit. Okay. So, and you can kind of see that again, we fly through, and again, I don't work this fast. We sped up the video on this just so you guys can kind of see how we do this. But the Nobel Biocare system again has got their surgical guide kit. They have the mounts and all that stuff that we use to place the implants using the surgical guide. This was flapless, so we went ahead and then just put healing abutments in these positions. And you'll see that in this case, depending on the position and then the position of the papilla and other things, sometimes I use round healing abutments, or sometimes I'll end up using the inattatemp healing abutments. And you can see in this case, we actually had a mixture of the two. And the inattatemps are actually hand tightened. So just keep that in mind. Everything else we torqued out. And we always take x-rays. This is another point I wanted to kind of make, is that please, please, please make sure you guys are taking x-rays. We've got, nomads where we take x-rays, during surgery and immediately afterwards. And you won't believe the number of times when you put something on an implant you think is fully seated and you take an x-ray, oh my God, it's not, right? So always, always take x-rays. And this is his, x-ray from after surgery, again, showing that everything's fully seated. And then, we're going to wait 4-6 months, and then he's going to be sent off to the prosthodontist to start working on finishing this case. And early on in 2016, we did a lot of the accuracy assessments with the thermoplastic guides, and this was published in 2016 with the help of Anatomage, where we looked at, how accurate are these, and then we looked at immediate versus delayed implant placement, and then to our surprise, actually our immediate implants, for some odd reason, were actually more accurate than our delayed. Okay, and it showed that our accuracy was under a millimeter. So with that mindset, then I started thinking, okay, wow, if our surgical guys are giving us that much accuracy, why are we not prefabricating things? And that's when I started doing the prefabrication of the temporary crowns. And then after that, I helped them develop what I refer to as a 3-guide technique, because before all of this, we were doing all on 4, all on 6s, and freehanding everything and then eyeballing bone reduction. So I came up with this method, and I still use this today for some of our select cases where we do what we call guided bone reduction. So this is a gentleman that came to me that had bilateral tonsillar cancer, underwent radiation, and obviously you can see that his dentition is just destroyed at this point, with xerostomia. So this is one of the early cases that I did using that 3-guide technique. And then you can see the guided bone reduction using that method. So, and we're still, again, using these guys with osteoid. And then this is his x-ray from afterwards. And this is almost, 10 years out at this point. And we also published this as well in 2016, what we can do with regards to guided bone reduction. And then after that, I was like, well, geez, okay, can we use that same method? Can we start doing cosmetic surgery? So then I started doing, CT guided genioplasty. So again, with the team at, Anatomage back then, now osteoid, we went ahead and actually created surgical guides that actually fit on the teeth. That's almost like a template for us to actually make the genioplasty. So, and then these are just some of the models showing that, hey, we want to move this patient's chin 6 millimeter forward, and you can kind of see from the plates that this is a 6 millimeter genioplasty plate that we put on. And then this is just some of the clinical intraoperative photos. And then this is him before and after. So just you can see with the movement of 6 millimeters, how much chin length we actually gain. And he was always self-conscious and wanted to have a more masculine chin. And then so this is him before and after. So again, you can kind of see the difference in how far his lower jaw protrudes. So, this is all happening in 2015, 16, and all that stuff. And then I got involved with Yomi at that point. So, there's a lot of naysayers out there, with regards to, hey, this, robots, this is not going to work. But, they've been here for a while now. Okay. And so as I started thinking, okay, hey, when was actually the first robot developed? Believe it or not, it was 60 years ago. Okay. And it wasn't the Jetsons. Okay. I don't know if all you guys remember, this cartoon. I remember this growing up. And it wasn't Rosie. Rosie was not the first robot. Okay, you guys. But if you just take a look at some of these depictions, it was almost like a foreshadowing of what was actually coming down the pipeline. So, if we take a look at this guy down here, right, or we'll look at this, or the assistant, or what's happening here, all of this stuff is now actually existing. Okay. So you guys all know about Roomba. I've got, I don't know how many of these things everywhere, like this one, 5 or 6 of them. My son loves playing with these things. But it wasn't actually in 2002, it was actually 1996. Electrolux was actually the first one to develop one of those first automated vacuums. And then, personal robot, Honda's got, the personal robot. The other day, I noticed that actually in one of the Tesla stores, they have their own robots. So, I mean, all of these assistants and stuff, this is becoming mainstay, but especially in Japan. Japanese, like I was in Japan and almost like 7 or 8 years ago, everything is robotic over there. You guys know about all these guys, my favorite. But then even if you take a look at this, believe it or not, there's actually a robot to wash your hair made by Panasonic over 10 years ago. And then this is literally what it does. You sit and you lie down in this machine, and this thing will actually wash your hair for you. Can you believe that? So, um, robots are coming into every facet. So, developed 1954 was the first one. And then now just imagine like all of the things that we have. So, this was the guy. So, George DeWall was the guy that invented the first robot. Okay. And then initially it was called the programmed article transfer, and then it was called the manipulator, and now it's actually called a robot. Okay. And that first robot was actually over 4,000 pounds. It was actually in the first GM plant in Trenton, and it was designed to handle hot metal objects and do welding and other things. And then this is today. If you took like if you go to Fremont and take a factory of tour, this is what you're literally going to see. It's just amazing. Okay. Um, but if we just look at like industrial robots and what's been happening, it's just that it's like this huge surge. And then this is from 2018. I can't imagine what the numbers are these days. Okay. And obviously Japan is always leading when it comes to robotics. And then, us and Germany are always, second or third. But it's they're every facet of industry, from entertainment to the beauty industry, transportation, believe it or not, pets, swimming coach, runners. So I don't know if you guys remember Jonathan Harris with B9, okay, Terminator, and then I don't know if you guys watched this Robot Wars. My son loves this program. And then again, we talked about this already. Cars, right? You guys remember Kit? I remember this, and then I found this clip, and then I was like, oh my God, this is actually San Francisco. So I put it in there. But now there's pet robots. You have actually a robot that swims and kind of will train you if you want to train for a triathlon. Um, but believe it or not, 1985 was actually the first neurosurgery using a robot, and this was the first needle biopsy of the brain. Okay, and then in 1988, first prostate surgery was using the Da Vinci system. After that came along, right? And then nowadays, there's actually a robot to do hair transplants. Okay, and before this, when I did my cosmetics fellowship, we had to learn how to do all those incisions. I don't know if you guys can notice what this is. This is actually cantaloupe. We'd have to sit there for hours and then using this knife to go ahead and make tiny little holes in someone's skull to be able to put those hair plugs in there. Okay. This is all now done with robotics, and these are the size of the knife. So like, literally 5 millimeters is, and you would literally manually would have to go and do this thousands of times. And these surgeries would take 6, 7 hours sometimes. Then came along Mako, and then Mako was actually the first robotic hip replacement system. Okay, and this was really the segue into Neosys because the people that developed Mako actually are the people that ended up developing the robot that today we call Yomi. And Mako, in 2013 was sold to Stryker for $1.5 billion, and at this point they do the majority of the knees and the hips. And then in one of their latest studies, they showed that, reduction in knee revision, excuse me, by 66%, you guys. I mean, it speaks volumes when it comes to robotic surgery and how it's improving patient outcomes. So in 2012, after Mako was developed, then the CEO of Neosys, his father was an endodontist. So then they started like, you know what, maybe we should get into dental field. So they came along, and then I got introduced to them, sometime around that time, and then we came up with Yomi to be able to do oral surgical procedures. Okay, and it was the first and at this point the only FDA approved fully guided, and I'll kind of go over what I mean by that. This is us, and this is Alon, that is the CEO of the company. This was one of my patients that introduced me to him. This is me, and gosh, I looked so much younger back then. But Alon's claim to fame is, I don't know if any of you guys watch football, but I don't know if you guys know that yellow line with the first down marker. He was actually the guy that developed that before he got into robotics, and he's a pretty smart guy and very, very interesting. But yeah, so that's his claim to fame. But this is what the Yomi looks like, Yomi robot looks like. And it's got really two arms. It's got a robotic arm, which has the drill on it, and another arm that's connected to the patient, right? So this is what we call physical guidance, where the robot is literally attached to the patient, right? And that's the advantage with Yomi. With all the other system, it's really camera navigation, and still really relies on freehanding, okay? So you have what we call dynamic surgical planning, and that's the biggest benefit of Yomi, is that sometimes during surgery, if I go somewhere and I don't get the bone that I want for an implant, I can on the fly change the position on the surgical planning, and then Yomi will actually change the drilling protocol. Okay, and then visual guidance. So what I mean by that is that the lots of times I'm not even looking in the patient's mouth. I'm actually looking at the screen. Okay. It's all real time. As you're drilling, you're actually watching the drill on the screen, working in the patient. So this is, just a picture of, what it looks like. So lots of times you don't even need to look in the patient's mouth. Okay. Then the other thing is that the physical guidance, like once you determine the path and the angulation, the depth that the implant's got to go, you cannot actually change that. The robot itself, believe it or not, is 400 pounds. You can't just pick this up. This thing is super strong. If you put your whole weight on it, you cannot make that arm move. Okay. And then patient tracking. So this is the portion that attaches to the patient, because the majority of times we're sedating patients, or sedated and not moving, but even a slight movement in the patient can actually be tracked using the patient tracker, and it's attached to the patient using this. And this is, I help them. I'm one of the people on the patent of this, is that we developed this to be able to attach to people's teeth or dentition. Now the latest version actually attaches to people's jaw itself, so that if somebody's edentulous doesn't have teeth, we can actually do all-on-4, all-on-6s on them by attaching something similar to this to the patient's actual jaw. Okay, so this is kind of go over this a little bit. So it's a little
You
smart
also have a
video.
tracking arm that is getting readings every time that the patient moves.
So if a patient moves, Yomi follows the patient and it adjusts automatically to compensate for whatever movement that patient might have. And patients can move pretty quickly. Yomi will follow it.
So the other interesting thing that it has is what we call haptic guidance, and it's really hard to explain unless if you really feel the handpiece, is that it will allow you to actually only move in the direction you're supposed to move to. And if you try to go into an opposite direction, actually you'll feel it almost like vibrating and telling you, hey, dude, you're going the wrong direction, right? And that, it's basically all tactile. And when you get into that cone of where the drill has got to go, it's much easier for you to actually move into that position. So again, Yomi is the only system that's out there that does everything from same-day surgery, minimally invasive physical and visual guidance. None of the other things, the camera navigation, surgical guidance, and all the other things, gives you that property. So, and I'm going to kind of show you guys a picture of how we actually do this, but we always, you place the splint on the patient's teeth, and then you get a CT scan with the splint in the mouth, and then you bring the patient back. And then in the software, you actually do the surgery planning, and then you connect to the patient, and then you perform the surgery. Okay, so I'm going to show you this. We just did this 2 weeks ago, where we did 3 anterior teeth and a guy that fell off a balcony when he was younger and had 3 fused crowns. So you can kind of see on the program here that I've tried to make the implants parallel to one another from a restorative standpoint, and that they're in a screw retained position. And we always try to place them more palatally, so that it allows us, so you can kind of see in that middle window there, that we're able to kind of get a screw retained restoration for the restorative dentists. And then this is us, taking the teeth out, and all of those three crowns are fused together at this point. But again, I never periotome in the buccal. I'm always going medial and basically distal of the tooth, because especially in the maxilla, the buccal plate is so thin. If you try to use a periotome on the buccal, you're going to fracture that plate. And that plate is really critical, and I'll show you guys later why, because we actually like to use that to maintain some of our grafting material. This is where we establish the landmark. You got to tell the robot, it's almost like a check, saying that, hey, listen, this is where I am, and it checks this off, and you can kind of see now we're just literally going from one tooth to the next, and then because they're all parallel, you just basically jump in. Here you're seeing in real time what happens as we put the implant in. We increase the torque, and then you can see it in real time the positioning of the implant as it's going in, and basically where we want to end up. And then the other thing I do is I like to always, especially in the maxillary anterior cases, to bone graft actually the buccal plates and the buccal shelf. So I'm doing a subperiosteal dissection. And again, a lot of these cases are flapless. I try to make sulcular incisions. We're not doing a lot of releasing stuff. And I always put a cover screw. Obviously, we don't want to get the grafting material in the implant itself. And I load up the grafting material in a 1 cc syringe, and we're basically tunneling that material buccal to the buccal plate of the implants. And just to kind of help out. And then lots of times what we do is we put even resorbable collagen membrane ahead of that. This is in this case we ended up using our anatotemps again to try to mold the tissue and get it ready for the final restoration. The patient's bite was deep, so in this case I didn't do immediate temporization. So this guy's going to actually end up wearing an Essex retainer. But this kind of shows us a little bit how we do these cases. Fluoromicro suture, we try to basically, I always like to have a turtleneck of tissue around it. So no matter what, even if it's flapless, I'm always putting sutures to kind of create a seal. And then the other thing I do a lot in these cases, I'll do a frenectomy, because I don't want, lots of times patients are curious, they'll pull on their upper lip, and then what they don't realize is actually they're pulling on the soft tissue that's around the healing abutment. So we just quickly do this, and then we close things up with a fluoromicro suture. So this is him on the day of the surgery, and we're going to closely basically monitor this. And then he will wear an Essex retainer over the top of these guys. So with Yomi, because the accuracy is under a millimeter, I mean, you can just imagine the possibilities for this, right? So I mean, just this morning I got a thing that with regards to tumor resection, right? You can do almost anything intraoral at this point. We're working on corrective jaw surgery, also orthognathics. I showed you guys the genioplasty, even tooth ablation. There's even some thoughts of using it to do endodontics for root canal. So, it's really limitless in terms of what you can get accomplished with this system. This was our first implant that was placed in 2018. And she was actually a dental assistant that used to work for a general dentist. And this is what her, number 30 looked like. And, before Yomi, I would say that there's no way I'm going to be able to get an immediate implant in a case like that, right? But with Yomi, we were able to actually go ahead and immediately place the implant. And we obviously graft around this, right? And I always like to also do soft tissue grafting and other things on top of all of that, just to kind of build some extra layer, basically over engineering, right? So, but I use this implant system for our molars. These are what we call Keystone. They used to be Southern, in order for us to get primary stability. So in the molar positions, I like to go with at least a 7 or an 8 millimeter. I always think of my 9 millimeter as my emergency. Okay. And this was, again, we were the first person in basically in California to use this system. If you guys are more curious about this, I highly recommend you guys go to their website. It's called neosys.com, and they're based out of Miami. Okay. And as of last count, they have over 200 robots now. So it's really taken off. Now let's get into, I guess, the Invivo and the surgical guide. So I'm sure that you guys recognize this login. And with regards to how you guys order guides, but I don't know if you guys noticed, but now there's a new option which they call the new guide design file, which is basically an STL of a surgical guide. So in the past, what would happen is that we would do the surgical planning, send it off to Osteoid or Anatomage, and then they basically mail us the guide. Now I've been doing some of the beta testing for them, where they basically send me literally a day later, they email me the STL file. of a a surgical guide, and then we print it in-house. Okay, so and this is the difference. So which is really minor. And the way that you can tell whether if you have a thermoplastic guide versus a 3D printed guide is that there's no metal sleeve. Okay, and in our Sprint Ray 3D printer, we actually use this very tough material because I was a little bit concerned with regards to, okay, well, we don't have the metal cylinder. Is this thing going to melt as that drill is going? Actually, it doesn't. And we've used this multiple times at this point, and then we're not getting any melting of that 3D printed surgical guide. The surgical guide is going to look a little bit different because you see that there's multiple holes, and this is a 3D printed model and then a 3D printed guide. But if you look real carefully, this is where the implant goes, not the other holes, because one of my staff is like, "Whoa, Dr. Massoomi, look at all these other holes. What are these for?" This is to make sure that your guide is actually fully seated. Okay, so when we put it on the model, that's how you can confirm that it's seated. But yeah, the actual implant hole itself does not have a cylinder. Okay. Um, so with regards to, cost, and because I had a lot of people ask me, how much does this cost? What material do you use? So again, I use Sprint Ray. Okay. And, once we get the new guide design file from Osteoid, then we spit it in basically into our machine. And the cost for us, material cost, is about $8 to $10, believe it or not. It takes us 40 minutes to make these guides. And you can print them at different microns. And what I mean by that is that the lower the micron, the longer it's going to take, right? So yeah, we printed this actually at 100 microns. And then the material that we use is what we call surgical guide 3, which is a much tougher material. And then there's 10 minutes to wash and cure. And I'm going to show you later, how the system kind of works. Also, what we've gone into is actually printing temporary crowns. And this was like the holy grail for me because, when those patients, like that Berkeley student that would come to me, the first thing I would say is that, listen, you got to come back 2 weeks later. I got to make you a guide. I got to make you a temp. And all of that stuff takes time, right? Now, I can literally do those cases on the same day. Okay. So, and the cost for me to print these temporary crowns is $1. Okay. And it takes us an hour and a half to do these things. I'm going to kind of, take you through a case that we recently did. So again, we use the new guide design, and I'm going to kind of show this to you guys outside the mouth. So what ends up happening is that once we put the implants in, I stock all of these angled abutments. So in the patient's mouth, we put this in, and then using our intraoral scanner, we scan the patient. So basically it becomes like almost like crown and bridge at this point. And then we take that, and at this point, I still have to have a lab involved. So I send it to CDA, or I'll send it to Sprint Ray, and then they'll actually spit back to me an STL file for the temporary crown. So this is that same patient where the implant went in, and then on top of that implant, we went ahead and actually put these stock abutments, angled abutments that we got from Nobel. And again, I stock all of these for these interior cases. And then this is basically what the cost is. And they've got different heights. They've got, the 1.5, 3 millimeter, and 4.5. So depending on where my soft tissue is landing, I'll pick that different type of stock abutment. And then from there, we can go ahead and 3D prints the temporary crown. And outside the mouth, I'll go ahead and cement that temporary crown on the actual abutment itself, and then place it in the patient. These are just different views of that same temporary crown. And then this is a comparison of the tooth that we took out and actually the temporary crown that we 3D printed. So fairly close to one another. And then this is it immediately after placement. So this patient came in, we took the teeth out, okay? We went ahead and put the implant in using the surgical guide. And then we also then on top of that went ahead and put a 3D printed temporary crown. So, and again, we can do all of this now the same day. That's how far things have come. It's just amazing. This is her, the same patient, 6 weeks later, right? There is no way me or anybody else can honestly recreate this type of soft tissue afterwards, right? This is why I'm a big proponent of trying to do immediate temporization, because it really, helps to save that papilla, which makes the case, again, much easier for the general dentist down the road. This is a video I'm going to show you how we do this case. So this is us using Yomi. So again, when the patient is awake, we go ahead and use, it's almost like blue mousse. It's a very stiff material. We put that on the patient's mouth. We tighten it down. And then we put the fiduciary marker. This is when the patient walks and gets a CT scan. Now he's back, he's sedated. You can tell based on the nasal cannula, the patient's out at this point. And so then we go ahead and make a sulcular incision to try to take the teeth out atraumatically, okay? And obviously, again, with this case, I use periotomes on the mesial distal aspect, try not to go facial, to try to remove the tooth atraumatically and intact. And again, I don't move that fast. This video is sped up a little bit. And we try to remove any of the granulation tissue, either Paradex, normal saline, whatever you can to kind of cleanse the wound. And then this is where I'm making a tunneling basically area for the grafting that's going to come later on. This is where we attach the tracking arm from Yomi. And this is us now telling Yomi, hey, this is where we're at. I'm in the distal pit of this tooth. And then once we have established landmark, it's a confirmatory test for the robot, then we start going to the site itself. And I'll tell my staff, hey, go guide it. And then it will literally put me in a position where I determine the implant to go. And then every time that we take the drills out, you have to tell the robot, okay, now we have a 3.5 by 22 millimeter drill, right? Because it's not going to know how long the drills are. And then again, we go freehand, and then I tell my staff, go guide it, and then boom. So it literally, honestly takes 5-10 minutes to do that sequence. This is us after we've placed the implant. Now I'm getting ready to do our bone grafting. And I have a lot of, people ask, how we do this. That's why I wanted to kind of make sure that we have this in this video. Again, we put a, cover screw on the implant itself, and you can kind of see that we inject that material buccal to the buccal plates, okay? And then on top of that, as I'm going to show you in a little bit later, we're going to put a resorbable membrane. It's just, again, and it's another extra layer. I mean, he's got, he's not a thin tissue biotype patient. He's got very thick attached gingiva, but in all of these cases, I like to always bulk up, the buccal aspect. And again, I stress all of you guys that please, please, please torque your crowns, final crowns, whatever it is you put on an implant, always torque them down, okay? You won't believe the number of times we get patients to come in with bone loss, periimplantitis, because the crown was not torqued down. I've even had patients sometimes when they go into the general dentist for the final crown impression where the healing abutment wasn't torqued down, they swallow the healing abutment. Here I'm showing how I do my vertical sutures. So even though it's flapless, I like to, again, create a seal. I want to really make sure that none of that grafted material is going to come out of the facial. So I like to always put these things in. And then I think we have a picture of him 1 week later. Yeah, so this was basically his, temporary crown that was 3D printed. And then it was luted outside the mouth. This is it, screw retain position. Immediately after surgery, this is what it looks like, okay? And again, we leave these out of occlusion. So you can see it's maybe a millimeter shy of the other, right? And this is him basically a week later. And then I monitor these closely. I see them a week, 2 weeks, and then 6 weeks out. And if it looks good at 6 weeks, then we basically let it go, okay? So now we've also started to print hybrids for, all unfortunate. This is literally what they look like when they come in. Cost is $8 to $10 at most. It may take us maybe about 2 hours to make these things. And they're custom made, where in the old days, we would have to have the dentist make a traditional denture and we cut holes in them, right? So we don't do that anymore. So if you take a look, this is what they look like outside the mouth. And this is the case that we did recently. This gentleman came in with a 2-jaw hybrid with an upper and lower 3D printed hybrid prosthesis. We're printing models now because lots of times when patients come in, if we can't do the immediate implants, we got to have an Essex, right? So I would have the general dentist make an Essex. I don't even have to do that anymore. So they don't have to waste all that money for an Essex that they may never end up using. So if I can't put it in immediately on site, I go ahead, scan the patient with our intraoral scanner, and then spit out the STL to my, Sprint Ray. They print me a model, and then I have my staff do a suck down on top of that for us to make basically an Essex retainer. So, in a case like this, when the patient comes in, you can kind of see that I wasn't able to, go ahead and, put the implants in. We do our grafting, and then we make an Essex retainer, and the patient goes home with that. So we make that all in the same day. Now, AI is coming into this too, right? Because remember, I talked about the design of the crown. We still have to spit that back out to a lab and have somebody manually do it. But now a lot of things are actually AI generated. So this is an AI generated this night guard that actually I made for myself, right? Cost was $35, took us an hour to do this, okay? And we printed this as 100 microns, right? And then this is a video of how we actually do that. So AI is going to come into temporary crowns, hybrid prosthesis. I mean, I can't imagine what the next 10, 15 years is going to do. But this kind of shows you the system that we have in our office and how we actually 3D print things. And it's all very similar to one another because you have your printer, your wash, and the post-cure. So this is what we call additive technology. You'll see that tray go up and down, up and down. And what it's doing is adding basically layers, layer and layer. You can kind of see like, this is showing you how many layers there were for the night guard, which was about 170. And then this is Rogelio, who's my techie guy. He loves this stuff. This is like his baby. Showing you kind of, how we do this. So we basically have to wash that material. And then once, the material is washed and it comes off the platform, then he cleans it with alcohol and then puts it in the curing machine for about 8 minutes. And we had to do almost no adjustments. It's amazing how accurate these things are. So, and he's going to kind of take you through the portion where he polishes and all of that. And then this is where we're removing some of the excess material. Again, Rogelio is not that fast, okay? And it's amazing. So basically, you send this over to SprintRay, and then it spits back out this AI generated night guard. It's just incredible. So, in summary, guided. Okay, robotics and 3D technology is here to stay. Okay, you cannot fight it. It's like a tsunami that's coming, and you gotta embrace it. And the sooner you do it, the better off you're gonna be. Okay. Now I'm all over the web. If you get a lot of my contact information is here on my website. I have, Facebook. I honestly do not keep track of other people doing that for me. I have a YouTube channel where I have some of these videos actually posted. But if you have any questions about today's talk, please feel free to reach out to me at drm@bayareasurgicalarts.com. And that's it. Thank you so much.
Thank you, Dr. Massoomi. I'm going to give us a couple minutes here as we wrap up the hour for some of the questions that have come up. So one of the questions that I can see here is related to your 3-guide method. Someone is asking, do you find more accuracy and consistency with using that method where you're using those multiple guides during a all-on-4 or all-on-6 type of case?
Absolutely. So I don't know if you saw that paper that we published in 2016. Our accuracies were under a millimeter, right? So it basically was reducing the bone where we needed it to be. Yeah, and bone reduction is one of the linchpin when it comes to these types of procedures. And one of the biggest things that I see is that when patients go to somebody that doesn't do a lot of these things, where they just take the teeth out and just putting implants in without bone reduction, the restorative portion becomes such a challenge. Like I can tell you so many times I have patients that come to me where that's happened to. I got to take all the implants out and then do the surgery all over again and do the bone reduction. So I do not freehand any of those all-on-4, all-on-6, all-on-8, or all-on-X, whatever you want to call it. But absolutely, yeah. I think as of last count, I've done over 100 of those cases using that technique.
Perfect. Another question that comes in is related to the trephine tips. The question is, how do you typically restore the bone after removing it with those tips? And do you see good healing post
Yeah,
removal?
the bone grafting doesn't change. Yeah, so I use cadaveric bone, especially again if you're going to go anywhere where an implant's going to go, I don't recommend use bovine. You want to use cadaveric bone. But yeah, so it's the techniques are all the same. So sometimes I used Dynablast from Keystone, or the putty material that you get from Nobel, and I mix it sometimes with just freeze-dried cortical cancellous bone to give it a little bit more volume. And I just pack it as best as possible. I always over bulk. So because we all know that you pack 10 millimeters of bone, you're never going to get 10. You're always going to get less. So I always over bulk. Yeah. So the technique isn't really that much different. So then what I do is I do try to preserve the attached gingiva, and I don't try to basically bring the buccal tissue all the way to the palate. So I will actually go ahead and do bone grafting, resorbable collagen membrane, and on top of that, I'll do a cytoplast or a non-resorbable so that we keep that attached gingiva. So when I go back, I've got a thick, attached gingiva there to put our implant through, because as all of us know, it's really helpful to have 2 millimeters of attached gingiva all the way around an implant. It really helps to prevent peri-implantitis.
Perfect. Last question here, and then we can always answer the additional questions post. It's more related to the Yomi, and maybe you might know this. Will it be hands-free someday?
No, never. Yeah, FDA's never. I had a question. I had one, and this is the thing, is like, because I was at NBC News, and then we were talking about this, and I had some guy drove down all the way from Marin, and he's like, and he comes and look at the robot. He's like, "Oh, you have to actually operate it." I was like, "Yeah, what did you think? It's like a press a button, it's gonna come at you." But yeah, even if you look at the Da Vinci, all the robotic systems that are out there in medicine, none of them are automated. Now, there is word that in China, there is actually one that they're working on that's fully automated, but I don't think in my lifetime we're ever going to see a robot that's fully automated. It surgically assists us, basically.
Perfect. And I guess let me just grab this last one and then we'll wrap up here. Let me find it here one more time. It was regarding your genioplasty guides. They were wondering if your plates are custom made or if you have a specific manufacturer for them.
No, they're stock. So if you look at, like, I use KLS for that case. KLS, or many of the implant companies now, the plating companies, I'm sorry, they have prefabricated and pre-cut, so you can order 4 millimeter, 6 millimeter, 8 millimeter. They're all basically pre-packed.
Perfect.
Yeah.
Thank you, Dr. Massoomi, and thank you everyone for joining us today. We look forward to seeing you all again in our next webinar here. I believe it should be in May. Look out for a follow-up email from us with a link to this webinar recording, and then we'll answer any questions as well that went unanswered. But I hope everyone has a great rest of their Friday and a wonderful weekend. And thank you again, Dr. Massoomi, for joining us.
Thank you for the opportunity. All right, guys. Don't forget, guide it.
Bye, everyone.
Bye-bye.